until good. So patient preparation for a chest x-ray is going to start by involving removing any radio-opaque objects, okay? Opaque objects are going to be things that will show up on the x-ray, okay? Mostly anything that's in the way of the chest, including clothing, will show up on chest x-rays. With the exception of certain things like, very thin undershirts and stuff like that, okay? You'll notice that almost every time a patient has a chest x-ray taken, they are put in a gown, right? We know our gowns are radiolucent. They are designed to be thin enough and made of light enough material to where they don't really show up on x-ray, okay? And importantly, everyone wears the gown, so if they do show up on an x-ray, everyone's got that artifact on the x-ray. It's something that is not going to change necessarily. Now in the book, it'll often show the patient without a shirt. That's fine. Patients can be shirtless for chest x-rays. Some prefer to not put gowns on. That's fine. But we're going to want to remove any clothing artifacts. We want them to wear our clothes, our gown, okay? For people with long hair, right? Those hair ties, hair fasteners on the PA or AP will end up showing up in the chest, okay? Even long hair, right? Those of us that have long hair ends up showing up in the x-ray. And typically long hair is going to extend down into kind of the upper lung field. It ends up showing as a haziness in the lungs, okay, which can potentially be mistaken for pathology, potentially be mistaken for disease. So make sure long hair is out of the way and any long hair fasteners are up out of the way. So we basically want everything to be above the shoulders, okay? Oxygen lines, pacemaker leads, we want all of those to be outside of the lung field, okay? So what you can do is, now typically if a patient's on oxygen, and let's say you're in your urgent care, there's two common ways to prepare oxygen or to administer oxygen in the urgent care. There's either high flow oxygen, in which case they go for very short treatments of about 15 minutes at high flow, which is about 15 liters per minute. They have a mask on, the treatment happens, and then it's done, 15 minutes, okay? But there's other cases where patients are saturating very low in their O2 sats, and they will get a nasal cannula put in, okay? The little tube that goes right into the nose. Now that's low flow oxygen. So to be clear, and this is for medical purposes, medical assisting purposes, a patient will need a nasal cannula anytime their oxygen flow is less than 6 liters per minute. And anytime the oxygen flow goes above 6 liters per minute for high flow cases, you need to use a mask, a rebreather mask, okay? So patients who have a rebreather masks on are getting high flow oxygen, okay? And those treatments will be done very soon. You'll do the x-ray after the treatment is done, okay? But there will be cases where patients are oxygen dependent. Either they came in and their oxygen saturation is low and we're going to put them on long-term oxygen therapy the whole time they're there, 3 to 6 liters per minute typically, and we use a nasal cannula. That's not going to necessarily be taken off for the x-ray. Or maybe the patient is just oxygen dependent. You probably know people that have an oxygen tank that they carry around with them, right? Now, in those cases where they're oxygen dependent, you'll need to check with the physician. Can I remove their cannula? Okay, can I take their cannula out for the x-ray? Can I just take it off, put it off to the side, take a couple of minutes to take the x-ray, and then put it back on afterward? If that's not the case, if they must keep the cannula on, because I said the rebreather masks, they can just do the treatment, then after the treatment we can do the x-ray. But in the case where their long-term oxygen therapy is happening, we're going to want to ask the physician, can we take their O2 off? Okay, and if we can, we do. If we cannot take their O2 off, then you need to take the oxygen line and move it somewhere where it's not going to be in the way of your x-ray. What I like to do, and there's always tape in the x-ray room, I like to take the O2 line, run it up across their shoulder, and tape it to the top of their shoulder. It will be there in the x-ray, but it's not within the lung field. Okay, so if you're stuck not being able to remove their O2 line, get it out of the way of the lung field. Okay, run it across the top of the shoulders is a good example. Pacemaker leads, those are surgically implanted, not coming out for the x-ray. So you're not going to be able to necessarily remove those. Now what I think they mean are electrocardiogram electrodes, right? Those the connections for the ECG. Now in a hospital setting, patients are hooked up to ECG and they're basically just kept on it, okay? If that patient got an x-ray order, you can ask the nurses, can we remove the ECG for the x-ray? If not, then you're just going to have the ECG lines in the X-ray, and there's nothing you can do about it. And the radiologist is going to just know that they have to do their best to interpret the X-ray with these artifacts. However, if the ECG electrodes can be removed, then we remove them for the study. Okay, it's all going to boil down to asking their treating providers, right? Either the physician or the nurses that are treating, helping to treat the patient.
Is there a requirement that you document that, or like
Potentially?
Like I know, we're in a clinic setting, but you can type in notes and say,
right. So notes with exam, right? Study notes, things like that. Contrast notes, allergies. So there's always room for all that stuff. Yeah, so add it in as a comment, right? Now you have to make sure that where you're adding the comment in is a place where the radiologist will be able to see the comment. For example, sometimes certain places where we enter information is only visible to us in the X-ray room when we go to pull up that exam. Other ways to enter comments, those travel with the image to the radiologist and are part of the exam that the radiologist gets to see. So make sure you enter it in the right spot. Otherwise, you're going to get a grumpy radiologist going, why didn't we remove such and such artifact from the image? So the way to think about it is anything that gets in the way of the anatomy we're trying to look at is called an artifact. We want to minimize artifacts when possible, and if we cannot minimize an artifact, we're probably going to end up making a note about it. Okay, something, right? Some sort of note that is letting them know that we thought about that we at least asked about it or tried. Okay, there could be, there's in the chest, people get nipples pierced sometimes, or dermal implants that don't necessarily come out, right? Piercings that don't come out. Those don't come out. We're going to add in a note: patient unable to remove, piercing, right? Artifact is present. Go ahead.
Do implants show up?
Yes. Yeah, you can actually read the CC amount on some implants. If it's at the right angle to the image receptor, you can read the CC amount. Yeah, so you can see implants. Yeah, all the time. It's another artifact, right? That's not going to go away. Patients who have especially dense nipples, those show up on X-ray, okay, and that can be an artifact. We call it a nipple artifact, okay. That's part of the patient, right? Certain artifacts are part of the patient. Other artifacts are removable. Remove the removable ones. Don't remove the unremovable ones. And by the way, random note, in the case of the nipple artifacts, they look like densities in the lungs, like a nodule in the lung, right? It can look like that. Usually looks like it on both sides, though. What the physician will have you do, and it's kind of goofy, they'll have you we have these sticky BBs. You guys seen these in the X-ray room? It's like a teeny little BB on a little piece of like sticker, right? And you'll ask the patient to put this directly on top of your nipple and stick it right to their nipple. Take another X-ray with the purposeful artifact now, and now if that nipple marker shows up where the old artifact was, we know it was their nipples and not some nodule in the lungs, right? So we have techniques for seeing if these artifacts are artifacts or if they're true pathologies. Yeah, goofy stuff. All right, so remove artifacts. That's a good part of patient preparation. For radiation protection, now you guys will go through an entire 3 months of radiation safety. Some of you have done it. So there's more to come, but important things to think about. Limit your repeat exposures. Minimize repeats. That means you're doing your best to minimize errors, right? You're doing your best to position correctly, to collimate correctly, to set the right technical factors. That limits exposure. Every time you repeat an X-ray, you're doubling the exposure from that image, right? Every time it has to be repeated is a whole nother exposure. Collimation, for those of you who may not have heard the word before, collimation is controlling the size of your radiation field, okay? Attached to every X-ray tube is a box. That box, called the collimator box, has a light in it, projects a light towards the patient. You can see that on this image. There's a light projected onto the image receptor. And we can make that field, some of you know this, but we can make that field bigger or smaller, okay? We want to collimate to the size of the anatomy that we're looking at, okay, and no larger, okay, and no smaller. For almost every study you'll perform, patients will be given some type of shielding for the gonads typically, testes and ovaries, and so you'll notice down at the patient's waist there's sort of that burgundy red lead apron around their waist. That is proper shielding. Notice how it wraps around the patient, right? The patient's in lateral right now. We want that shield to protect their side that's facing the X-ray beam, and importantly and often forgotten, the side that faces the image receptor.
Yeah, I was about to ask that too, because I mean it comes back.
Yeah, there's backscatter. In fact, there's a big debate about whether you should shield to the front or to the back between with chest X-rays, and people are going to argue about it. I'm one of those people that says you should shield the patient's front so that when they're facing the receptor, PA, right? I'm one of those people that says you should shield to the front to protect from backscatter, because if you think about where the gonads are in the body, male or female, they're towards the front of the body, right? If their back is to the X-ray beam, the beam has to get through all of that body tissue before it gets to the gonads. The body effectively acts as a filter, right? But in the front of the body, their gonads are not protected from the front, males and females, right? So we're not protected from backscatter. So I'm one of those people that says you should shield to the front. In this case, the patient's shielded to the front, but that shield also wraps around their sides too, because they're small enough. If they're larger and the shield does not wrap around to their sides, you would actually want to rotate the shield to one side for the lateral projection. Now, whether you rotate it to the image receptor side or to the X-ray tube side depends on if you're a shield to the front or shield to the back kind of person. That's going to come from whoever trains you. Okay, you'll probably end up using the tips and tricks for the people that you actually get, are hands-on with in the X-ray room, and that's fine. Both of them are correct. There's not a right or a wrong way. We just like to argue about things as X-ray techs. Here's an example of our lateral. Today, by the way, for image evaluation, we're only going to be working with AP, PAs, and laterals today. You're not going to actually be evaluating on these view boxes any lordotics or any decubitus X-rays. There might be a couple decubitus, but there's no lordotics, nothing weird looking, okay? But this is our lateral, okay? Showing correct shielding, correct collimation. You'll notice the collimated field, the square around the anatomy, includes all the anatomy, includes the entire lung field, okay? Top to bottom, including the entire lung field, front to back, including the entire lung field. And you'll notice at the bottom of the screen, bottom of the image, there's this sort of whited out area here, right? That's not the patient. That's the shield the patient's wearing, okay? That's showing proper shielding on the image. Oops, don't ignore that. I got bumped around here. Okay, let's talk about technical factors. So chest x-rays are all done at high kV. Now, can anyone remember from last time what that is a controlling factor for? It's an electrical setting on the console, right? You have to change it with every exam. What does it affect, changing kV? Contrast, and there's one other thing you should think about it affecting.
Brightness.
Not brightness. It's something to do with density, but not directly, and that's not the main controlling thing, but it's good that you've got that. It affects the penetrating power of the X-ray beam, okay, which thereby will end up affecting contrast. Now, is high kV associated with long scale contrast or short scale contrast? So let me rephrase it. Is high kV associated with many shades of gray or very few shades of gray?
Very few.
The exact opposite.
Oh.
High kilovoltage settings are associated with many shades of gray, which is equivalent to saying is associated with long scale contrast or low contrast. High kV equals low contrast. That's why chest x-rays just look kind of gray. There's grays, different shades of gray. There's not a lot of black and white on a chest x-ray. That would be high contrast achieved by using low kV settings.
Trying to find the definition for this online is difficult when you try to type in radiology.
Mm-hmm.
So radiology definition, so I had to go and look it up under photograph.
Yeah, photography terms will help. Try radiography as your keyword instead of radiology. Yeah, it might help. It might, I don't know. Anybody use Quizlet?
Yes.
Quizlet's hugely helpful, okay? A lot of the radiology Quizlet stuff is for RTs, but it's still hugely helpful. Quizlet's great. There's another website called Rad Review Easy, which you have to pay for, but it's really, really good. I mean, it got me well prepped for my RT exam when it was time. I did it for the RT school. Yeah, I don't know. Did you see how much it costs now?
I think it wasn't expensive.
It was like $8 a month when I did it.
Yeah, it wasn't expensive.
Yeah, I mean, you pay that much for or more for streaming services, right?
Yeah,
Cancel one of your streaming services for a couple of months and add on
really high
Rad Review
reviews.
Easy.
That's what I was
Yeah,
looking at.
it's the
It has
best one.
really high reviews.
It's the one that the schools use. Yeah, that the RT schools use.
What's
Yeah.
it called?
Rad Review Easy. Yeah. Yeah, and when I did it, it was like $8 a month. It might be a little more now, but again, we pay that much for streaming services, so cancel a streaming service, add that on. That's my advice. Yeah, but Quizlet's free. Quizlet is really easy. It's good, but it can be sort of funky sometimes to operate on, depending on your computer. Anyways, good. Other technical factors to consider. We do use a grid for chest x-rays, okay? I won't talk about too much about what grids are now, because we have a whole thing to talk about them later. But grids increase contrast. Grids increase contrast by removing scattered radiation from the image. Fogginess, it takes away the fogginess. And then the third note on here, it says high milliamperage short exposure time. What we think about with chest x-rays is we just want to make sure we have a short exposure time, the shortest possible exposure time. What do short exposure times help with? Help minimize? So not necessarily. Movement is the main thing, right? Patient movement. Distortion caused by movement. Yeah, absolutely. Patient movement is the biggest destroyer of image quality, right? And so you want to shorten exposure times to minimize the possibility for motion. There's something in the chest that's always going to be moving, and that's the heart. So keep that in mind, right? Short exposure times, minimize motion. If the heart blurs on a chest x-ray, it can make the borders of the heart look blurry, and to a radiologist or to a physician, it can be mistaken for pericarditis, for a heart infection. So good. Do I have a question over? Yeah.
Did I read it right, or was there a machine that allows you to see the image before you even take it?
No.
The digital, I think I read where it says like they can see. It was in this chapter. Or
Interesting.
Number 2.
So no, there's direct radiology, which gives you the image as soon as it's taken. Oh. There's that. Nothing's going to allow you to preview or anything. No. Now in abdominal films, we take something called scout images, where we go take images before we take our images, but that's a different type of thing. Yeah. If you find where it's at, let me know so we can see if it's a mistake or something, or if it was just a misinterpretation. Yeah. Either way, go double check what you had read. All right, patient identification. We got to ID every exam. Okay, so you'll notice on film X-rays, there's often a little film tag at the top, which gives patient information such as name, date of birth, hospital, and a patient number, that kind of stuff. In digital radiography, that's just like attached to the image as a file in there. You can view that information. But on the actual image that you take, we need to include something called the anatomic side marker. Now the school will pay for your first set. So you'll get a set, it's got your initials on it. You'll put it on every x-ray that you take to mark if the patient's left, or to mark if it is the patient's left or right side. Either way, we have to indicate a side, okay? You'll notice in this one, that marker says L at the top, okay? So we know that as long as we trust the x-ray tech put it on the correct side, we know that side with the L marking on it is the left side of the patient's body. What do you notice about the direction the heart is pointing? To the right, yeah? So if the x-ray tech was incorrect, they placed it on the opposite side, the patient would get a wrong diagnosis of having a wrong-sided heart, okay? Situs inversus, which is written right there. If the x-ray tech was correct, which we have to assume they were, then the patient's going to end up getting a diagnosis of situs inversus or dextrocardia or whatever. But the point is the patient's heart is on the opposite side of the body, and we know that because the x-ray tech put an anatomic side marker down. This one has an anatomic side marker, but we can't see it, right? If you can't see the anatomic side marker, how do you know which side you're looking at? Which side is the left, which side is the right? Because just like you can with like images on Photoshop, you can mirror these images. You can flip them back and forth. We call them translating them, right? To mirror them left and right. So this could have been accidentally flipped around, okay? if you do an image in AP, and as an AP projection, but you tell the computer it's a PA projection, because you tell the computer what X-ray you're processing, the image will get flipped around backwards, okay? And if you didn't mark it, the patient could end up with an incorrect diagnosis of things like the heart on the wrong side. It actually happened at my urgent care. An X-ray tech put the marker on the wrong side because the computer flip-flopped the images. He wasn't paying attention to which direction the heart was pointing. The patient got diagnosed with dextrocardia. They left the building, and then I went back in and I said, hey, did you process this? He took it in AP, as in an AP projection. I said, did you process it as an AP projection? He's like, no, I just clicked the PA projection. I said, well, I have to remind him, it flips the X-ray around the wrong direction, and if you also put the marker on the wrong side, you're going to get a lot of wrong information going out to the physician, which the physician will just have to assume is correct information, right? So it's very important to put the markers on and put them on the correct side. You actually have to put a marker on the image. Every image has to have a marker, and by the book, every image has to have a hard marker. They cannot be soft markers, which are the ones that are on the computer that you add on. So technically, we have to have our hard markers on every image. What was your question?
I found it. It's on page 55.
Let's see what it says.
It says, DR and CR systems both give the technologists the advantage of being able to view a preview image to evaluate the positioning errors and confirm exposure indicators. The
Gotcha.
projection may be repeated immediately after.
Gotcha. So what they mean by preview in this case is the X-ray's been taken, but has not been sent over to the radiologist yet. So we are previewing the image that we made, so we can make potentially any corrections to it, and then we send the finalized image to the radiologist or physician. Good. That's important. Yeah, so DR and CR, the point is that these digital radiography methods allow you to view the X-ray before you're done with it. If you're working with film, when you view the X-ray, that's the final copy, right? If there's something wrong with that, there's no way to change it, to alter it. With digital, we're allowed to, we get our initial image, and we can potentially make changes to it before it gets over to the physician or radiologist. That's good. So yeah, so not viewing it before it's taken, but viewing it after it's taken and before a physician reviews it. Okay. Think about being in your X-ray room, looking at the X-ray after you take it. That's what they're talking about. Okay. With film, you didn't have that. I mean, you could look at the X-ray after you took it, but that was it, right? You either turned it into the physician or you redid it, right? Yeah. So higher rates of repeats in film radiography for sure. Okay. Every chest X-ray is going to get a breathing instruction. Most chest X-rays, all with the exception of one type, are done on inspiration, a breath in. Can anyone recall which one type of chest X-ray is done on expiration and why?
Oh, I know this. Was it to see the way?
You're doing this, so I think you've got it.
Yeah, I know it. To see the way that the lung, I guess, in my terms, lets like the air out.
Yeah.
The way it contracts and the way it.
Good. So it's to diagnose pneumothorax when there's a collapse of the lung, right? That's why this is what I saw. Yeah. I saw you collapsing the lung. So a pneumothorax may not be visible on inspiration, or maybe like mildly visible on inspiration. But if you do an inspiration and expiration study, do one on breath in, one on breath out, it can be easier to see the lung collapses a little bit more on the breath out, so you can see that. But all other ones, good job, all other ones are done on inspiration, full breath in. Now to be clear, and they say it right here, the exposure should be done on the second full breath in, okay? There's two reasons for that. Your second full breath is always going to be deeper than your first full breath, okay? And when you take the first full breath, your body starts pushing blood back to the heart, so your pulmonary vessels start to get a little bit congested and filled up. Okay, on the second breath in, that should more or less have cleared out. Okay, so it clears up pulmonary congestion, which may look like heart disease on a chest X-ray, which would look like some stuff going on in the lungs and the heart on an X-ray. So second full breath, there's always a good reason for it. Please do that and don't get into the bad habit of doing it on just one breath in, which is what a lot of x-ray techs do because they forgot what I just said. Yeah.
After reading the book and like looking at the positioning, I found a really cool note to have them like throw their shoulders forward.
Mm-hmm.
So I wasn't doing that before. I was also doing it on the first breath, but I did like kind of like the way that I just got into this book at this point. Like it started to make a lot more sense now.
Yeah.
So I started to make a couple of changes. But the guy that I work with, I mean, he just kind of like let me like figure out some stuff on my own. So his way of teaching is like, you're gonna trip before you get better at it, right? So I started paying attention to a couple of the tips that this thing does, and it makes the biggest difference in images. It's really cool to have them throw their shoulders forward too, and gets the scapulas out of the way.
Yeah, clears up the lung field, right? Especially if you're looking for upper lung pathologies, the scapula, it's a bone, right? Bones get in the way of, it's an artifact basically in the chest. So rotating those out of the way is a huge important step to take. Good. Okay, good. So we have breathing instructions. We do them on purpose. We walk them through the breathing instructions. Try to be concise with your breathing instructions. Please do not overcomplicate this, right? Take a deep breath in, now let it out. Take another deep breath in, hold your breath, right? Simple, clear instructions, okay? Keep in mind that children will almost always turn around when you say something to them. So tell them you're going to give them instructions and remind them to keep still when their instructions are given, okay? People with learning disabilities might do similar things, and you will need to learn how to say it in Spanish. Okay, so who has done? I can say it, but who else speaks Spanish and has given the instructions in Spanish? Yahaira, what do you tell people in Spanish to take a deep breath in, let it out, take another deep breath and hold it? What might you tell them? One more time. Okay, so I will say something like respire profundo, right? Breathe deep, right? And then you want them to breathe out, right? What do you say when you want them to breathe out? Los suéltelo. Okay. So I'll say respire afuera, right? Breathe out, right? So afuera, A-F-U-E-R-A, afuera. So breathe in, breathe out. I didn't say I was good at Spanish.
You know that I cannot repeat what you just said.
So the point is you're going to need to be shown how to do this, right? Yahaira, what do you tell them when you want them to hold their breath? Deténgalo, right?
No, sosténgalo.
Sosténgalo?
You can say it both ways.
Okay, I learned deténgalo, so again, different ways of doing things, right? The point is, you're going to need to know how to give this instruction in Spanish, okay? The majority of your patients will either speak English or Spanish. Very few will speak other languages, and when they do, you're going to access your language line in your facility,
What you
okay?
can do too, well, you can call it a language line, but you can go on
Google Translate.
type it in English, and then just push the little speaker button, it'll replay it for them.
Sure, so you can use your phone to do that, right? I like Google Translate when I'm dealing with like in a room with a patient, like for doing medical stuff. I never actually ended up using it for X-ray, but it's there, right? You can use those things. So keep in mind you will have to know how to do this in at least one other language, okay? In a lot of cases it's Spanish. A lot of places that we live have large populations of Spanish-speaking patients, so learn this for where you're gonna work. All right. Anyways, the point is we give good, clear, concise instructions. Okay. Good. The erect position that we do. Right, we're going to talk about the erect position in just a moment here. The reasons for erect, a couple of different reasons. Sitting upright or standing allows the patient's lungs to expand more. Okay. When we lay down, you guys ever like eaten a big meal and then like went to lay down and that like food baby pushed up on your lungs and made it hard to breathe, right? A similar thing happens when we're just laying down, right? Our abdominal organs push up on our diaphragm, making it more difficult to expand our lungs. We breathe better when we're seated upright. The diaphragm goes down further. Air fluid levels are best demonstrated when the patient is erect. Again, I showed you with the bottle, right, that liquid goes to its lowest possible point, right? So if the patient is tilted or laying on their back, that liquid, which otherwise would have been visible like that, ends up spreading across the back of the lungs, okay? Or the side of the lungs, right? The point is the erect position allows you to visualize air fluid levels. Liquid goes down, air goes up, and you can see those things. Laying on the back also causes congestion, engorgement, enlargement of pulmonary vessels, kind of like what happens on the first breath in. So seated upright prevents that.
So engorgement of pulmonary vessels, I mean, there's just more blood in them?
Yeah, they get packed with blood.
So if you're breathing, you're in the laying down position, does that mean that you're just oxygenating your blood better than if you would if you were standing up?
No, the blood's not moving as much. So you're not oxygenating your blood any better. Kind of sort of the same, but you're not moving that blood as effectively back to the heart and out to the body. Yeah. Good. So evaluating our radiographs, right? There's nothing useful on this page, but the point is there is an optimal radiograph, right? We usually show optimal radiographs in the textbook, right? The pictures you see are typically the optimal ones, which gives us a objective standard, right? We have stuff that we look for on every X-ray. We're going to talk about these in just a moment. Giving established standards for each position or projection, which means that if I go take a chest X-ray on a patient, and then that same patient goes to your office, then you take a chest X-ray on them, those two chest X-rays should look the same, assuming the patient hasn't had some major pathologic change between here and there. We should take the same chest X-rays, okay? My chest X-ray should not be Alex's special chest X-ray, right, that only Alex can do. Everyone can do it, and we all do it the same because there's, again, established standards, which I'm going to get to shortly. On chest X-rays, we want to minimize rotation, okay? The APPA and the lateral, we want to minimize rotation. Now, in the PA or AP view, the way we check for rotation is by looking at the clavicles. More importantly, where the clavicle, see right here where it's sort of the outline, where the clavicle meets the sternum. We want to pay attention to where those proximal ends of the clavicles are in relationship to the spine. Okay, so I'll come over here. You'll notice the spine is in the back, right? And the clavicles are towards the front of the body. Okay, so the body's three-dimensional, and if you rotate the body, the ends of these proximal ends of the clavicles, they're going to move left or right in relationship to the midline, in relationship to where the spine is. Okay, so for example, if the patient rotates with their right shoulder toward the image receptor, again, let's assume you guys are the receptor, patient rolls their right shoulder toward the receptor, well, their left sternoclavicular joint moves away from the spine, and their right one moves toward this midline of the spine. Okay, roll them the other way, the right moves away, and the left moves towards the midline of the spine. Okay, so you can notice that the patient is rotated by looking at the sternoclavicular joints. Okay, the rule you want to follow is you want each proximal end of the clavicle to be equidistant from the midline of the body, from the spine, the midline of the spine. You want it to be the same distance. Okay, one's closer than the other. That's evidence that you rotated the patient, or that the patient was rotated. Okay, yeah.
What if they have scoliosis?
Good. There's pathologies, right, that we're going to have, and so there's unavoidable pathologies, right? There's a couple things. Scoliosis, to be clear, is lateral curvature of the thoracic spine, right, bending of the spine. To be clear, almost everyone has some degree of lateral curvature. There's normal lateral curvature, and it's almost always to their dominant side, but it will change the relationship, right, of the spine to let's say, the sternoclavicular joints in this case. And you almost can't do anything about that, okay? You're just going to try to position them as straight as possible, right, so that they're not leaning one side or the other side towards the receptor. And yeah, if they're not equal on that patient, that's okay. But on all your other healthy, otherwise average patients, this is a quick, easy indicator for rotation. Okay? Physicians look at this too, okay, so it's not just an X-ray tech thing. Doctors are going to look at this and they're going to know the patient's rotated, okay? And then they may want you to repeat the X-ray depending on how rotated that patient is, okay?
And so the instructions to the patient would be to stand with your back to the...
Yeah, back against the board, or back or chest against the board.
Do they need to pull their shoulders back or
forward? But we'll talk a little more about that as we go. Yeah. Another thing to think about, right? Maybe I'll stand further. Another thing to think about is when you go to position your patients, you want to put their chest against the board, right? Or let's say their back against the board so I can look at you guys, right? But you also want to pay attention to where their feet are, okay? Patients might stand with their feet kind of funky, okay? 1 foot farther forward than the other, right? Or 1 foot further back than the other. That's going to rotate the lower body, which can then translate to some rotation in the upper body. Even if they think they're flat against the board, they may not truly be flat against the board. Either way, front or back facing the board. So watch where their feet are, right? And then move their feet if you need to, right? Or tell them to move their feet, right foot forward slightly, left foot backward slightly, whatever you need to do, give them the instruction so that their whole body can be straight, so they're not potentially rotated in any direction. You want them to extend their chin, okay? So it's common enough on a chest x-ray for the patient to come up to the board, hands on the hips like you have them do, rotate the shoulders forward, and when they do this, they drop their chin like that, okay? Shoulders forward, chin up, okay? Most image receptor buckies, most wall buckies, things hold the cassette, have this little chin pad on the top, this little metal chin pad, okay? You almost always want the patient to have their chin resting on that chin pad, if it's PA, which most are. If the chin is down, that's going to superimpose over one of our important structures, right? The air-filled trachea. So, chin up. You want to minimize breast shadow. Male or female, people with large breasts, they get in the way. That extra density lower in the chest gets in the way of the lower lung fields, and pathologies tend to hang out in the lower lungs, right? So you're getting an artifact, body artifact, in the way of where pathology likes to hang out, okay? And it's gonna, in this case, you'll notice the lower lung fields just look a little hazier, a little lighter, a little brighter than the upper lung fields do, okay? It's because the patient is large-breasted. There's not a lot you can do, but there's one thing you can do. You can have the patient, you've got to just be blunt about it, they need to lift, separate, and press their chest against the board, okay? There's no bra, so they could just move their breasts, right? They lift, separate, and push against the board, okay? That is the best you can do to minimize breast shadow. All right, let's talk about the hand, or rather, the placement of central ray on an X-ray. Okay, so AP, most of this has been notes on AP, but these are going to apply to the lateral as well. AP or lateral, doesn't matter, or lordotic or decubitus. You need to place the central ray in a spot on the patient. The central ray represents the middle of the X-ray beam. It also represents the strongest, straightest part of the X-ray beam that's going to give you the highest definition, but importantly, it's the middle, okay? And you want to center to the mid-lungs. Now, typically the PA or AP image is your first one. Once you've done your PA or AP positioning, you don't need to change much when you go to the other positions. Assuming the patient, let's say they're standing erect, they're not going to change in height, right, from either facing toward or away from the image receptor to turning. So once you place central ray for the AP or PA, you shouldn't really need to change it for the lateral. Has anyone been shown to change positioning, change placement on the lateral, move the X-ray tube up or down when you take a lateral chest X-ray? Some do, some don't. You change the collimation, right, but you're not going to move things up or down necessarily. Good.
It depends on the patient.
Yeah, I'm one of those people that says in almost all cases you're not going to need to change anything. You just turn the patient. So let me show you how to find the mid lungs on people. And I've talked about this last time, but just to clarify. One method, it's called the hand spread method. Now you can carry a ruler around if you want to, but you'd be better off to know how big this is on yourself. Measure it on a ruler, learn it, know this distance between pinky finger and thumb, how far those can spread, your widest distance. Measure that. Measure the width of your hand. Use those two things as measuring sticks, okay? This full pinky to thumb hand spread method can be used as a ruler. And on females, typically it's about 7 inches down from the vertebra prominens, and males about 8 inches down. Vertebra prominens Okay, that is Atlas. Good. 1, 2, 3, 4, 5, 6, 7. Okay, this is vertebra prominens. It is the spinous process for cervical vertebra number 7. Okay, this marks the highest possible point that you would need your collimated field to go to. Okay, you do not need your collimated field to go above vertebra prominens almost ever. Okay, that's above the top of the shoulders, and the lungs are not above where the top of the skin is. Okay, but you'll use vertebra prominens to put your thumb or pinky finger there, and let your pinky finger or thumb, whichever one's down here, in this case my pinky finger, to fall where it falls. Right, that point on this person's back should be their mid-thorax. Okay? Now if you're coming from the front, your bony, on the back, your spinous, vertebra prominens, spinous processes are your bony landmarks. From the front, your bony landmark is the jugular notch. Okay? Distance to mid-thorax from there is about 4 to 5 inches. Roughly speaking, the width of your hand. Okay? So palpate jugular notch, place your hand on the chest. Where your hand stops should be mid-thorax. That and that should be the same level on the body. Okay? Coming from the front or the back, you should be able to find the same level on the patient, which is the mid-thorax.
So the jugular notch to where?
About 4 to 5 inches down from that. It's the body of the sternum, but there's no like point to be at. On the back, you're pointing to roughly T7, but on the front, you're not. You're just pointing to the middle of the sternum, so you have to use the distance. Yeah.
Can you go back to the last sentence, please?
That one?
Yeah.
Yeah. Everyone okay so far? Man, we're taking longer than I wanted. All right, let's jam through this. Collimation. Your light field, your radiation field, needs to extend above the shoulders. And so this is how I do it. It's how you should do it. Don't worry about how far down it's extending. You will have to think about that, but you don't need to actually worry about the bottom of the light field. What you're going to want to do is, when the patient is in position, you're going to want to find where the central ray goes. Okay, place the central ray first. Okay, leave your light field extended as big as the cassette is. So if your cassette is placed, do I have a cassette in here? Well, she's just right now. My cassette is placed vertically, right? Then my light field is 17 inches tall and 14 inches wide. Okay, I'm going to find where the middle goes, right? Where I put the central ray on the patient. Okay. And then I'm just going to make sure that I have light extending above the shoulders. If I have a lot of light above the shoulders, I'm going to shrink my collimated field down a little bit. If I have no light above the shoulders or just enough light, which is just light poking above the top of the shoulders like you see here, I'm not going to change anything. Okay? As long as you place central ray correctly and include light on top of the shoulders, the bottom of your collimated field will be down low enough to include the entire lungs, like are shown here. Okay. The most commonly missed part of anatomy on a chest X-ray are these guys here, the costophrenic angles, the bottom lateral aspect of the lungs, most commonly missed. If you place central ray correctly and you include light on top of the shoulders, you will get down low enough to get the costophrenic angles. All right, so now we're going to talk about our actual chest exams, then we're going to do our image evaluation. So, standard are the PA and lateral erect. They call those routine on this one. The special images, including the two that I listed, but there's some other ones too. There's AP supine or semi-erect, lateral decubitus, which I've included, AP lordotic, which I've included, and then there's the oblique views. the entire time I've been an RT or an XT, I've never done an oblique chest x-ray. Doctors don't order them, almost ever. I mean, they may, but I've done oblique rib x-rays, tons of those, but obliques of the chest are very infrequent, are ordered very infrequently. It's just not common. So I'm not going to focus on it. I'm going to focus on the ones that we need to know.
I've never heard of it.
Yeah, they do them to look at the heart, great vessels, trachea. We can do all of that with the AP and lateral in ambulatory medicine. Now, there's reasons why these other positions exist, but we don't use them. If they need that much information, the patient's just going to go get a CT. We're just going to go get a CT of the chest, and we've got all the information we need. More than all the information. Yeah, so those oblique positions are rarely ordered now. Yeah, they're still there. Still got to know that they exist. All right, so let's talk about the PA. So in your book, the PA chest should be page 90. Okay, that's your ambulatory patient. This is where we're going to use our positioning worksheets. We're going to fill these in as we go. This is how you're going to get good at understanding and learning these positions, is by you're almost, but not exactly, you're almost transferring information to the worksheet from the textbook, but that's how you learn it. All right, so the position or projection for a PA chest, we call it a PA projection. So the position or projection is PA. If you want to include the specific part which says erect, that's fine. But when we say PA, we mean erect. Okay. Why do we do the x-rays? Well, that's when on our worksheet, that's what's listed as number 2, the clinical indication. The indication is why would you do this x-ray? Okay. Well, because the doctor ordered it, right? Well, why do doctors order PA chest x-rays? Well, let's read from right here. PA chest x-rays demonstrates things like pleural effusions, pneumothorax, atelectasis, or infection. That's the why. So if you're following the textbook, hopefully you found where it says clinical indications in the text. Pleural effusion is liquid, fluid in the pleural space, not blood in this case, liquid. Pneumothorax is air in the pleural space. Atelectasis is any reduction in lung volume due to an obstruction, okay? So you guys have heard of a pneumothorax, right? A collapsing lung, right? Well, most people, when they think of a collapsing lung, they think of like a hole in the chest, right? Letting air into the chest, pushing down on the lung, okay? The lungs can actually collapse because of an obstruction, all right? Let's say a small child who doesn't know better goes to eat a coin, right? It happens. Kids eat stuff all the time. They put things in their mouths all the time, right? Well, let's say instead of eating and swallowing the coin and it going through their gut, them having to get like some crazy exploratory gut surgery to get it out, let's say they accidentally aspirate it. Let's say it goes down into their breathing tubes, okay? And it makes it down their trachea. So it's not blocking breathing completely, but it blocks one side. It either blocks the left bronchus or the right bronchus at the level of the carina. What you'll have is, you'll have one side blocked. Now when air goes to rush in, the other lung is going to fill, and the lung that's blocked is not going to fill. It will collapse. It will stay squished down, okay? That will cause atelectasis, collapsing of the lung. So atelectasis is, the technical definition is any decrease in lung volume. Volume is how big your thing is, right? Any decrease in lung volume caused by obstruction. The layman's way to say it is anytime the lung is collapsed, okay? Now, the lung can collapse because some kid aspirated a coin and blocked an entire side, but it can collapse pathologically too. Let's say a disease process blocks one of the bronchial ducts, one of the roots in, right? It doesn't have to be a main one. It blocks, let's say, a lower one, right? The lower lung, the lobe that's affected will collapse, okay? So wherever the collapse is happening is where the obstruction occurred. So the obstruction can be in one of the large bronchi or a small bronchiole, but either way, obstructions in the lungs will cause atelectasis, a collapsing of the lung, which doesn't always look like a pneumothorax. A pneumothorax and atelectasis are two different things. Okay, let's talk about technique. It's number 3. Technical factors. Source to image distance is always 72 inches or longer. Image receptor size is a 14 by 17. Does anyone have a 17 by 17 receptor where they are? No. If you only have one receptor because it's a DR system that goes straight to the computer without any connection, it's almost always a 17 by 17 square receptor nowadays. It's been the kind of the new standard because in the past our films were 14 by 17 inch. Those are 14 by 17 films. This is a sleeve with 14 by 17 film. You'll notice the film is longer than it is wide. Okay. And this was to save money, okay? In film days, this was to save money, right? You could either place the film vertically like this for tall, skinny people, or sideways like that for big, white people, okay? With digital radiography, we've now just made our image receptors 17 by 17, so there's no more turning it back and forth. You just change your collimated field size, your light field size nowadays, okay? But the textbooks will still reflect the fact that we've been using film is the standard, and even with CR, computed radiography, our image plates are still, the biggest ones are 14 by 17. Okay, but some new DR systems use a big square plate that is 17 by 17. Anyways, plate size, big, the biggest one.
Alex, I have a question.
Yeah.
Some of the tests that we just took, some of the answers, it was in centimeters.
Yep.
It was 183 centimeters. Was that a trick? So you know it's like not the right one, or is that correct?
Probably not a trick. But
it says right here 180 centimeters.
Right. If it's at 183, they might be trying to trick you. Yeah. Yeah. So
I thought it was 180.
Just turn it into inches, right? Divided by 2.54 centimeters to inches. Okay. And then you will get the inch measurement. And if the inch measurement isn't 40 or 72, then you know that they're trying to trick you on the quiz. Yeah. That sounds like a trick question. It was the quiz we took today?
Yeah.
What do you know? Do you know which one it was?
No, I don't remember which one.
Oh, it's right here. 72 inches is, oh, well, it's the right answer though. Anyways, that's the right answer. I don't know why they put 183. 180 is close enough to 72 inches. I think 183 is more exactly 72 inches. So that in that case, I don't think they were trying to trick you. Small difference in the way the test looked, but yeah, so not a trick in that case. The answer was right if you answered that one. Yeah.
In a lot of jobs where you're an X-ray tech, do they often because I know that when we order like X-rays or we order whatever CTs, sometimes would it be our place to be like, hey, if I see what your diagnosis is and what you're trying to image, but the image what you ordered is not correct.
You can run it by the doctor, yeah.
And then let them know before it's even done.
So yeah, an RT can actually change the exam. An RT can say, we need to add on this extra image, we need to subtract images, but an XT is not supposed to do that. Mm-hmm. An XT is supposed to consult with the physician. So if you think what's ordered is different than what the physician requested, you want to consult with them. Or sorry. If you think what's ordered is not going to demonstrate what the physician's looking for, you can say, hey, because they might just not know that you have these other tips and tricks, other positions, projections, and you say, hey, I've got this other projection. It's going to show such and such better. Would you like that instead? And they'll go, no, I know what I want, or oh yeah, that's a good idea. But either way, run it by them. Yeah. Okay. That's happened a lot. Where I know special projections at the elbow that show things that you don't get in the standard ones, and physicians order a standard X-ray. I say, hey, what you looking for? Oh, a radial head fracture. I said, hey, I've got a way to do this where I'll show that radial head fracture where it might not be visible in the other images, and you want me to give it a try?
Yeah. For me, it's helpful.
Yeah.
That's what I was wondering if that's part, if we can.
Yeah, don't come at physicians don't like to be attacked. Don't come at them like, hey, you ordered the wrong X-ray, but hey, you want to try it? You want me to try it this other way? We might demonstrate such and such better. Yeah. Run it by them. Yeah, it's a good idea. Okay, good. Grid is yes on chest X-rays. So you say grid, yes. KVP, 110 to 125. mass is variable. On these ones that we're working with, you're not going to have to write down a mass number. You will consult your technique chart in the X-ray room for mass. Patient shielding. My recommendation for chest PHS is to shield the patient's gonads to the front. Okay, so waist shield oriented to the front of the patient. When you're doing these, you should be writing these down in a way that you can understand it, right? You're not necessarily copying verbatim what the book has. You're writing down the information, but in a way that you're going to be able to look back on it and go, oh yeah, that's helpful, right? Anybody could just copy the information. I'm trying to get you guys to take the important stuff, use that. All right, numbers 5 and 6 and 7 are some of your most important, okay? 5, 6, and 7 deal with the patient, the part, and the beam, the x-ray beam position, okay? Some of the most important. You'll notice that these two, patient and part position, have the most information listed here. This is where all of the important stuff is on how to put the patient in the room. So here's how you think about it. Patient position says, where is the patient in the x-ray room? Okay, we know they're in the room, describe where they're at, okay? Part position is, now that we know where they're at, how exactly are they positioned for that projection? Okay, so let's look at patient position first. Patient is erect, feet spread, weight equally distributed. They're standing. The chin is raised, resting against the image receptor. We have their hands on their lower hips, so that describes hand placement, okay? Shoulders are rotated, elbows partially flexed. Shoulders are rotated forward. Rotate the shoulders forward. Why? It allows the scapulae to get out of the road, to move laterally to clear the lung fields. Shoulders to press downward to move clavicles below apices. It's a multi-step motion. Hands on the hips, shoulders forward, and then rolled down while the chin is up. Okay. The thing that happens sometimes in these when we position is there's a tendency for patients to, when you position their shoulders and roll their shoulders forward and ask them to put their chin up, they kind of stick their butt out and lean like that. Okay. We don't want them to lean. We want the chest against the receptor, then the shoulders to roll forward. That'll keep them from doing this leaning thing. If you lean, remember, if you lean, you're changing air fluid levels. Okay, you're changing the position of the liquid or fluid air in their lungs. So patient position says, where are they in the room? Well, now we know from this they're standing against an image receptor. We know where their feet are. We know where their hands are placed. Part position is much more specific. Part position says, align the mid-sagittal plane with the central ray and the midline of the image receptor. CR is central ray. IR is image receptor. What's the mid-sagittal plane of the body? What's the mid-sagittal plane? So we know there are planes of the body, right? What is a plane of the body? You're doing it, you're showing. But what is a plane? Yeah, it's an imaginary sheet of paper, right? Imaginary two-dimensional sheet that can divide the body up into different ways, right? I can imagine a sheet of paper running through my body right down the middle that, if it was there, would make me into a left side and a right side, right? I can imagine another sheet of paper that would divide me into a front and a back, okay? And I can imagine another sheet of paper that would divide me into a top and a bottom, okay? These are sagittal, coronal, and transverse planes. We should learn these planes of the body, okay? So the imaginary sheet of paper, the imaginary plane of the body that divides the body left and right is called sagittal, okay? So you could take a sagittal plane, an imaginary sheet of paper, and divide my arm off of my body, right? You could divide 2/3 of my body to 1/3. I got 2/3 on one side, 1/3 on the other, okay? Or you can make an equal division. Run that imaginary sheet of paper right down my middle, right? My midline, or my mid-sagittal plane, okay? Said in another way, they're saying center the body to the image receptor, okay? But we have to use technical terms, so the technical term is align the mid-sagittal plane to the central ray and the midline of the image receptor. Our X-ray tube, imagine the patient removed here, right? Patient's out of the way. This cross here is going to be centered to the image receptor, because it is, okay? We just want to bring the patient in position so they're also centered. You have three things to position, right? You have, where is your X-ray tube, where is your patient, and where is your image receptor? You want to make sure all three things are lined up. My advice for you is, before you take the patient into the room, make sure image receptor and X-ray tube are lined up, okay? The correct wording is we put the X-ray tube in its detent, D-E-T-E-N-T, detent, okay? So the X-ray tube is detented to the image receptor, and then you just walk the patient in, right? Bring the patient in, and now you center them, and all you're gonna have to do now is maybe move things up or down a little bit to adjust for the height of your patient.
That bugs me at our clinic because it's not completely centered.
Oh yeah, there's an offset.
Yeah.
They will all be slightly offset. When I say perfectly centered, I'm lying to you. They will all be slightly, they will all be slightly offset. They must be aligned to within 2% of the SID. So at 72 inches, it's something like 1.5 inches of offset is appropriate, okay? At 40 inches, it's like 3/4 of an inch, okay? So there will always be some offset between where the light field says the center is and where the center actually is, okay? And it may not line up perfectly to the image receptor, but you just do your best. Okay?
Staring at that picture now, that's 4 units because one of his shoulders is more lit up.
Oh yeah,
than the other.
oh yeah, he's not perfect. Okay. So part position, tell me where things are, right? So align mid-sagittal plane, center the patient. Ensure no rotation. The mid-sagittal plane should be perpendicular to the image receptor. The mid-coronal plane should be parallel to the receptor. The plane of his body that divides him into front and back, the coronal plane, needs to be parallel to the receptor, so he's not rotated away or toward the receptor on either side. Okay?
So the order you line it up is CR, IR.
And then bring the patient in. Now, not to confuse, remember there are 3 things. There's the image receptor, where that's at, where the X-ray tube is at, and where the patient's at, right? My advice is line 2 of them up before you try to bring the 3rd one into position, okay? If those 2 things are the patient and the image receptor, that's fine. And then you bring the X-ray tube into position, okay? But don't try to move all 3 things around at the same time, okay? Typically what most people do is, and maybe you guys can tell me yes or no, what I would do for a chest X-ray is, I'm gonna bring no patient in the room, I'm gonna put the X-ray tube and the image receptor at the same height, roughly where I think the patient is gonna need them to be, right? If I know the patient's very short, I'm gonna lower them. If I know the patient's very tall, I'm gonna raise them. But I'm gonna make sure the image receptor and X-ray tube are, both oriented to each other, they're centered to each other. And then I'll bring the patient in, I'll perform the patient position, part position stuff, right? And then I may need to move X-ray tube and image receptor up a little bit or down a little bit, but I'm otherwise in very close position to where I need to be. 3 things to put into place, put 2 of them into place first, and then bring the 3rd one in. You will get confused if you try to move all 3 things around at the same time. It just is going to confuse you, okay? Too many moving variables. Okay, so move one thing at a time. All right. Central ray, this is the hand spread method, 7 to 8 inches inferior to the vertebra prominens, or let's see what they say, perpendicular to the image receptor. That's important. We know we're not angling downward, we know we're not angling upward, we're going straight towards the image receptor. Recall from last lecture that angling the central ray causes distortion, so we're just going to make it straight at the image receptor. We don't want to elongate the chest or do anything funky. And make sure the CR and IR are centered, but ideally you did that first. Collimation. Collimate on all 4 sides. Include the area of interest. Now, area of interest is going to change between exams, but for a chest X-ray, the area of interest is going to be above the top of the shoulders, okay, the illuminated field should be above the vertebra prominens, and the lateral borders should be to the outer skin margins. You should just see some light like this going outside of the skin and hitting the image receptor on both sides. That will ensure that there's enough light field to include all of the lung field and then a little bit of background. Patient instructions. Every exam is going to have a patient instruction. In the case of chest x-rays, it will be to suspend respirations on the 2nd inspiration. But you don't tell that to your patient, right? You tell your patient breathe in, breathe out, breathe in and hold it, right? But the wording is suspend respirations, stop breathing upon the 2nd inspiration. Take 2 big deep breaths. and hold it on the second one. Okay. We're next going to look at what do we look for now. So we did everything. We brought the patient in, we positioned, we gave them instructions, we shot the x-ray, okay? And now we're going to go look at our x-ray, look at these x-rays, which is what you guys are going to be doing shortly here. So we want to know three things. What anatomy is demonstrated, or did we demonstrate all the anatomy? Did we get the right exposure done? And did we get the right position achieved? Okay, because you can achieve the right anatomy, but not in the right position. For example, I can show you a chest supine, but that's not the right position for an erect chest x-ray.
So for these pages, all these are going to be the exact same?
Well, so that's what you're about to discover, right? Is that there's some differences, but there's going to be a lot of similarities too. The lateral and AP and decubitus are going to go a lot quicker, okay? Because we've already got down the meat of this, right? For example, technical factors, they're not going to change for any of the chest x-rays. All four of them have the same technique, okay? All four of them have the same or similar shielding. All four of them will demonstrate some similar anatomy, so there's going to be some definite similarities, and that's an important part of doing this. But let's get down to evaluation criteria. That's in that pinkish salmon color sort of thing at the bottom of the page. So anatomy. Both lungs, from apices to costophrenic angles. We visualize the air-filled trachea. How do we get the trachea full of air?
Breathe slow.
You breathe in.
We breathe in and hold it, right? We take that breath in and we hold that breath, right? If it's done on expiration, the trachea will not be air-filled and will not show as not shown very well on any of these, but will not show as a nice density, right? Density right down that where the trachea should be. Air-filled trachea is demonstrated because of the breath in. We see the hilum. What's the hilum? It's not a single part of the body, it's an area. Not a pocket. The hilum is where all of the vessels, so here is a terrible x-ray, but all of the vessels come back to the heart. You see this kind of increased brightness right here around the heart on either side. The hilum is where everything comes back to the heart, and that's a denser, brighter, whiter area on the x-rays. So you want to see the hilum. You want to see the heart. Great vessels, including the aorta. Bony thorax are all demonstrated. So now that you see the anatomy you want to see, that's, by the way, that's going to be the lab exercise today, is you guys are going to be taking chest x-rays, and you're going to be, as it shows up here, pointing out anatomy on them, okay? So we're going to have to get good at that, okay? You are going to be so tired of looking at chest x-rays by the time we're done with this, but that's a good thing, I think. Actually, everyone ends up really, really loving this exercise, so. Positioning. The chin is sufficiently elevated to prevent superimposing the apices. We saw what that looks like if the chin is dropped, right? So chin up. Sufficient forward shoulder rotation to prevent superimposition of the scapula. If you see the scapula in the lung field, you know you didn't have sufficient forward shoulder rotation. Is there anything that might prevent that from happening? Like prevent you from getting their scapula rolled forward?
Shoulder injury.
Shoulder injury is a good example. Arthritis, you know, so trauma or chronic pathologies, right? Something that prevents them from moving. The most common one though is just poor patient instructions. Okay, you didn't give good enough instructions to the patient. It's not their fault, right? It's our fault when we make mistakes. If maybe you gave them great instructions and you walked away, and as you walked away they relaxed and you weren't looking, right? That's patient instruction. That's where we're failing at patient instruction. We need to explain things in a way so that they understand, if I move, I'm going to have to repeat the exam, and I don't necessarily as a patient want the exam repeated. Breast shadows eliminated as much as possible. We would see that by the breasts being otherwise more lateral than they would normally appear. Distance from lateral rib margins to vertebral column, the same on each side. That's evidence that we did not rotate them, but you can also look at the sternoclavicular joints. Collimation margins. You want about as much, let me just bring the x-ray up. You want about as much light field on top of the lungs as you have below the lungs, okay? You don't want the lungs centered to the top and a lot of like the abdomen showing, okay? This, I know there's a lot of sticky notes on here, but this is a great example of a poorly positioned chest x-ray. There's a ton of abdomen here, right? And the lungs are all the way at the top. That's how much is on top of the lungs, that much, right? And that's how much is on the bottom of the lungs, right? This one is not centered well. They needed to bring the image receptor higher, bring the x-ray tube higher, right? All to move the patient on the image for the patient to be moved downward.
Unless they're an alien.
Unless they're what?
Unless they're an alien, because that's a really tall person.
Yeah, but when we can easily correct for that, right? We can raise things. Good. Lastly, visualization of 10 posterior ribs. Count the posterior ribs. You should see 10 of them. 8 is the absolute bare minimum to turn in an x-ray. And you must, if there's less than 10, you must add a note. Patient unable to fully inspire, right? Patient has difficulty with inspiration. Something so that the physician knows you thought about these kind of things. Because otherwise they're going to think you're just a lazy x-ray tech just taking pictures and turning terrible pictures in. And that's not you guys. Exposure is the last thing you want to look at. No motion, evidenced by sharp rib margins, diaphragm inferiorly, the heart borders appear sharp, lung markings appear sharp, long scale contrast, allowing us to visualize the different densities inside of the lungs. It shouldn't just be a black lung, right? We should see different shades of gray in the lungs. Faint outlines of at least the mid-thoracic and upper thoracic vertebrae and posterior ribs visible through the heart, okay? You need to see the spine through the heart. If you don't see the spine, there's the spine, through the heart, we didn't use enough penetration. We didn't use enough x-rays. We need to go back and shoot it again. Alright. So I'm going to give you guys a tip trick kind of thing. Let me assume for the sake of this that you know what anatomy you're supposed to be looking at. So this is going to be more helpful once you're doing this for a little longer. So let me say a couple things. One, everything I'm showing you today is important. Good. You're not going to be good at looking at chest x-rays in one day. It's just not going to happen, okay? You're going to need to do this a lot, okay? It's going to take you about a year of being an x-ray tech, so a year outside of school, to where you're really confident and comfortable looking at your studies and deciding if everything is there and if your positioning and exposures are correct. But I can give you some tips and tricks that'll help you, okay? One way to do things is to shorten up the evaluation. That's a lot of evaluation, right? So let me give you one quick way to shorten up the evaluation. Assuming you know the anatomy that's present, and assuming that assuming you demonstrated all the anatomy, right? This is a positioning and exposure evaluation, okay? And it's quick and easy, okay? And it's an acronym that goes by RIP, okay? So not rest in peace, but rotation, inspiration, penetration. Secretly, that's positioning, and that's exposure, okay? Secretly, it's a shortened acronym for that big, long thing that we just did, okay? So this is what you think about, okay? You want to know if they're rotated or not. What's the first thing we're going to look for rotation on the PA?
A difference in the size, or
size of the lungs, left to right?
Spatial between the midline.
Right. So
from the midline.
Use a bony landmark, whatever bony landmark you want to use, and compare it side to side. I like sternoclavicular joints equidistant. Something like that. Sternoclavicular joints equidistant from the midline. Pick a bony landmark and use it. The clavicles themselves, the entire clavicle can be used. If their left shoulder is rotated toward the board, their left clavicle looks longer, their right clavicle looks shorter, okay? So you can pick a bony landmark and you can compare it side to side. I like sternoclavicular joints being equidistant from the midline. Inspiration. How do we know they took a deep enough breath? We told them to, and then when we look at the x-ray, like look at where it says position, And the last note on position says visualize a minimum of 10 posterior ribs, right? So 10 posterior ribs AD. What's AD? Not like after death, right? So what's AD?
Interior decubitus.
Ooh, good guess. Above diaphragm. Above diaphragm. That's a term taken from rib positioning, where we look at ribs that are above the diaphragm, AD, and we also look at ribs below the diaphragm, BD. So ribs AD, 10 posterior ribs above diaphragm. And penetration. Penetration is secretly exposure in the textbook, okay? So exposure says no motion. Let's assume you know how to know what motion looks like, so you can rule. You don't even have to think about that. Like that looks blurrier than any of the other ones, right? The one on the left. So let's assume you can recognize that. Let's assume we don't even have to include that in the evaluation, the short evaluation. Let's assume we don't need that for the short evaluation. So what do you need? You know how to look at motion, so what should you think about? You should think about, did you use enough technique, okay? High enough kV for penetration and enough mass to get enough x-rays to the image receptor, right? You know you did that if you see black inside of the lung, some black, not the whole lung, but some black shade inside of the lung like that matches the background, okay? And you visualize the spine through the heart, okay? So, density, so one thing, density within the lungs matching the black background, okay? 1, 2, the second thing is visualize the thoracic spine through the heart shadow. So you see the heart shadow, and you can see the faint outline of the spine. Okay.
You said that it's AD and BD?
AD means above diaphragm,
B-
BD means below diaphragm. You don't need BD for chest stuff, but you will need to know the term AD, above diaphragm. Alright. Let's talk about the lateral. This RIP can be easily adapted to the lateral, so bear with me. Lateral's on page 92.
And do physicians use AD and BD as references?
Yeah.
Or is that something radiologists?
No, they should know that. I have seen physicians who have no idea what that means, but they should, roughly speaking, know that. Yeah. And if they didn't know what the acronym AD means, if you just say above diaphragm, they go, oh yeah, I know what you mean, right? So, yeah. Physicians are trained to evaluate x-rays in a different way than we are, right? We evaluate for anatomy demonstrated, positioning, and exposure, right? Those are our 3 evaluation criteria. They do that compactified and then evaluate for pathology. That's their goal, is to evaluate, to find something wrong, right? Our goal is to just put everything there and demonstrate it in a way that they can use it to find something wrong. So we do slightly different things, but they still know what to look for. They'll still like count posterior ribs. They'll go, that person didn't breathe deep enough, right? How do they know that? Because they counted posterior ribs. Okay. That's rotated. How do they know that? Because they looked at the rotation. It's underpenetrated. How do they know that? Well, they looked for black, and they looked for, spine through the heart. They're looking at the same things that we are. All right, let's do lateral. What I think I'm going to do is I'm going to get us through lateral. We'll do our exercise, and then I'm probably going to send the other two as a do it at home thing, but we'll see how we do. So go to your other positioning sheet, the one that has lateral erect or lateral written on it for position protection. We'll be on page 92 of the textbook. Keep the PA1 next to you visible so you can see the differences and the similarities. So, clinical indications. Clinical indications are going to change slightly. You guys okay? Alright, we're good. So you're getting out the lateral sheet. We're going to work on filling that in. Then we'll do our activity. So the clinical indications change slightly. If you look at clinical indications, it's a 90-degree perspective, right? Everything's rotated by 90 degrees. What that allows you to do is do two things importantly, okay? So let me briefly just bring back up this PA, okay? So I'll tell you something that a physician told me, not because I made the mistake, but because it's a useful thing to know. The physicians, radiologists will think about it like this. In almost all cases, one view of a body part is nothing. One view equals no views is what I was told, okay? Meaning that you always need at least two views of a body part to demonstrate anything, okay? For example, if I say, this is the patient, right, and a PA chest x-ray, and there's a thing here in the chest, right, this little nodule that I've just drawn on there, right? What do you know about that nodule?
Not supposed to be there.
Well, but it is there, right? So what can we say about it?
We can say it's on the right side, but we don't know where exactly
So it's
in the cavity it is.
Good, so it's on the right lung, right? And it's that. So what does that give you, right? That gives you your left to right, okay? What else can we say about it?
It's,
Is it lower in the lung or higher in the lung?
higher.
Good, so that gives you another dimension, right? How many dimensions can you talk about on this x-ray? 2, left to right, top to bottom, right? Something's in the chest, that, you know where it is, top to bottom and left to right. What don't you know? And it's what you said, but can you say it again?
We don't know the depth of what that is.
Right, to say it in the way that I'm thinking about it, we don't know where it is in the third dimension, yeah? This could be on their skin, yeah? This could be on their back or anywhere between there, okay?
It could be a rod going all the way.
Right, this could be a frickin' 40-foot rod pointed straight, right, not a 40-foot, you get the point. This could be a frickin', anything pointed right through the chest, big, as long as it wants to be, and just in this view, it looks like a dot, right? Turn them to the side, and oh my gosh, all of a sudden you notice there's a big, piece of rebar running through their chest, right? You would have seen it, but you get the point. This gives you 2 dimensions, not 3. This is why physicians say, one view is no views, right? You need the second view. You need the lateral, right? So now, what does the lateral give you? This gives you 1 dimension front to back, and it also gives you what the PA gave you, top to bottom, okay? Those 2 things together allow a physician to localize a pathology, a foreign body, whatever it is, allows us to localize it to some area of the body. Tells us what it is. We now know. So we need that 3rd dimension, which is why we take 2 x-rays of the chest, okay? Now, for clinical indications, you'll notice that 90-degree perspective, that's important, gives you the other dimension, but look at what other pathology it gives you. Pathology situated posterior to the heart. Notice in the PA, you see the heart, right? But if there was anything behind the heart, you can't necessarily see that it's there, okay? So in this view, there's this space. It's like a triangle, okay? It goes by a couple different names. We call it the posterior sulcus or the retrocardiac space, okay? Either way, it's a triangular shaped structure, and I kind of drew this bad, but anterior to the spine, posterior to the heart, okay? And it's an area where the patient may have pathology. This part of the lung, in this general region, is lower than the front of the lung, right? So if they're going to have fluid in their lungs, the fluid is more likely to be back here, okay? And it may not be visible on the PA. The lateral would show it to you, or may show it to you.
so they're erect.
Yes. As well, harder to see, but you get to visualize the aorta. The aorta comes up out of the heart like that, goes behind the heart in front of the spine. You get to visualize the aorta, as well as you get a view of the hilum. So there's different clinical indications.
Is this photograph in the book?
Should be. Might not be exactly the same because it's an older PowerPoint, but it's equivalent to figure 259 on page 92. It's an equivalent image.
Is it like 260? Yeah.
Figure
260?
260 or 259, either way.
Oh, yeah.
They're the same. They're the same.
Oh,
They're the same. One's labeled, one's not. Yeah. But no, mine on the screen is a different patient though. Same position, different patient. So slightly different look, but the same stuff is there. Technical factors. Notice the technical factors didn't change, so skip it or copy it. I don't care. But the point is you don't need to rewrite all that same stuff. Rather, it is rewritten exactly so you can skip over it if you like. Technical factors have not changed. Shielding has not changed. Shield the gonads. What does change is patient and part position. That's where we have to get specific. So patient is erect, like they were for the PA. Their left side is against the image receptor. It's the same idea as putting the chest against the receptor for the PA. The left lateral minimizes enlargement of the heart because the heart is closer to the left side of the body. If they can't, or if the pain or complaint is right-sided, then do a right lateral. But the default is always left lateral. Weight evenly distributed. Arms raised above head. This will differ depending on who you are, where you are, what you do. But notice in this case, the patient's arms are above the head like that. Okay, they raised their arms. Now, what I often find is the case is when you have patients raise their arms. Punch me over the face just now. When you have patients raise their arms, they tuck their chin, right? So you need to remind them to raise their arms and lift the chin.
I tell them to lock their fingers together.
That works. Like that. That's fine. That's fine. Grabbing a hand grip that's there available to you is fine. Using an IV pole, right? Those IV poles that we usually just have at our disposal. Use that to elevate someone's arms. Hold them in place. Either way, get the arms elevated for this lateral. If the arms are left, hanging, or like this, or like this, or like this, anything that's not out of the way, then the arm ends up superimposing, becoming part of the image. And you want to avoid that when possible. I have had it where patients were stuck from surgery in this position, and a radiologist they had shoulder surgery, and the radiologist, all they needed to do was get a PA chest x-ray to clear them from atelectasis, which is lung collapse after surgery. And in that case, no big deal. Arm stayed in the way. Okay. I still went and asked the doctor, hey, can we move their arm? And they were like, no, they just came out of surgery. So try to remove body parts, though, if you can. Move the arms out of the way. And if you cannot, add a note into the study. Center, so part position now. Now patient position again. Where are they in the room? Part position. Now that we have them where we want them, exactly how are we going to place them? Center the patient to the central ray and image receptor anteriorly and posteriorly. That central ray should be no closer to the front of the body than it is to the back of the body. Should be on the mid-coronal plane. You can think about it in a different way too. You want about as much light field behind the patient as there is in front of the patient's chest. So you can look at the light field and their shadow to kind of move them around. In this case, the sagittal plane is parallel and the coronal plane is now perpendicular. It's the exact opposite of the PA, which makes sense because this is a 90-degree rotation from PA. Central ray does not change. Same as PA. Collimation does not change. You still need to include the entire lung field top to bottom and front to back. You may adjust the collimation a little bit, but the structures demonstrated are going to be the same. Respiration, patient instructions do not change. Anatomy demonstrated. Doesn't really change. Include the entire lungs. However, your positioning evaluation will be a little bit different. In the case of positioning, Chin and arms are elevated. No soft tissue superimposing over the apices. You can see the top of the lungs. You see that demonstrated in the textbook. No rotation. So in your RIP evaluation, for the lateral, our rotation check can't involve the sternoclavicular joints because now we're from the side, right? But what you can do is you can look at, when somebody's in lateral, their posterior ribs should be superimposed on each other, right? If they are rotated one direction, one set of ribs, left or right side, will show further back, okay? If that shows further back, then you're going to get separation between the posterior rib, the left side ribs and the right side ribs. They're going to separate like that, okay? And you're going to see that separation. If that separation on the screen is any wider than your thumb, right, between the overlap of the posterior ribs, they were rotated too much, okay? And you need to repeat it with them less rotated now. Does that make sense? Okay. So rotation, you look at posterior rib superimposition. You can see that on this x-ray in the book. Very, very good superimposition. The hilar region should be approximately centered to the image receptor. Exposure. Now, on the PA, we looked for density within the lungs. Black in the lungs matching the black of the background. Do the same thing here. The space that I would advise you to look at is the retrocardiac space here. There should be black here that is as black as the background is, okay? And when you see the heart shadow, you should see the ribs through the heart shadow. If you didn't use enough exposure to see ribs through the heart, then the heart was underpenetrated, okay? So you're looking at the ribs, you're looking at the heart, and you're looking at the air. So you're looking at the densest structures and the least dense structures, as well as no motion. Let's assume we can know what blurriness looks like. Okay, with that said, that's our lateral, okay? So now what we're going to do, you guys are going to use your textbooks, okay? I've got a view box here at the front. This view box can take two groups of two. So we're gonna get it in groups of two. We're gonna try to get into groups of two. That's the idea. Okay. So I'd like you guys to have a partner. Okay. And you're gonna be evaluating and completing your own films like I've shown, and I'll explain more over here. You're gonna be completing your own, but you're gonna work with a partner so you can bounce questions off of them. Okay. So you'll find a partner. This front view box can take two groups. Okay. So 4 people up here. Each of the back view boxes can each only take one group, so 2 people at each of those. And this one up here can take 3 groups. Okay, 6 people can work up at this view box. So 6, 10, 12, 14. I don't know how many people we have, but we'll make it work. Okay. If we need to, have a line for stuff, that's fine. But I think we'll be all right. So this is the plan. Okay. You guys are going to be. I'm going to put these studies out, these X-ray films out at these different areas. Okay. We're only going to be working with PAs and laterals today. Okay. The other positions, the other 2, I'm going to send home as a homework assignment. But anyways, we're going to be working with PAs and laterals, and what you'll have is you'll have these packs of Post-it notes. Okay. And I'm going to ask you to demonstrate some, show me on here where the anatomy is, okay? We're going to use these as, this is kind of be my guide, okay? And so, for example, if I ask you to show me where the costophrenic angle is, well, there's the costophrenic angle on this x-ray. So take a sticky note with an arrow on it, point that arrow at the costophrenic angle, label the sticky note, left costophrenic angle, point the arrow right at the costophrenic angle and stick the sticky note on there, okay? You'll have one sticky note that I just want you to put your name on. Okay, so you'll grab one of these, you put a sticky note with your name on it, somewhere down at the bottom side of the road, and then we're going to start to label some structures, okay? We're going to try to label as many structures as we're able to. I'll put the ones that we need to label on the board, okay? And that's what we're going to do. So once you just find a partner, go ahead and move around. We can set up, for example, we can use these desks to kind of write from, the table up here to write from, those desks back there. But you guys are going to end up kind of moving around a little bit. You'll want your big positioning book. At least one person in your group should have their big positioning book. let me start to bring out the studies.
Oh, yeah.
Photograph that guy was like,
I'm sorry?
I didn't even know.
It can be a group of 3, it's fine.
I was like, what the heck?
Yeah, so you've got these 2,
Yeah, I
right?
got
So
those.
all you're gonna end up doing is filling out those.
Just the other 2?
Yeah, because I can't send the X-rays home.
Okay, no, yeah, that's okay.
But you'll need to do the other 2 for the other supervision. That's the additional one.
Oh, okay. Okay.
Yeah, that's fine.
Okay.
Sorry. Try to stay close to the awning and you'll stay out of the
yeah,
rain.
it's okay.
My son's little buddy is football
Clavicle
buddy
fracture? Yeah.
in football.
Yeah, that'll happen. That's unfortunate. He looks alright though, that doesn't look like it's too bad.
I know, I couldn't believe it.
Yeah, definitely. Here, there's a big stack of them. Take whatever you guys need.
Busy yesterday, I saw you.
Oh yeah. Yeah, jamming around. Alright. Okay, so couple things. Please be nice to my x-rays. Okay, these are old. Some of these are from the 80s. Okay? These have been around here for a long time and they've lasted a long time because we take good care of them. So, things I want you guys to avoid, right? Avoid bending these unnecessarily. Avoid holding them with one hand, because when you hold them with one hand it creates pressure points and little crescent-shaped creases in the film, okay? So bending, creasing, we want to avoid that stuff. When we're touching these, try to avoid too much direct hand, finger touching right on the middle where the image is. We're going to grab these from kind of like the edge, okay? Other than that, nothing too special here. I'm going to pull these 2 down. In fact, you know what, we'll bring this one pretty much interesting, but we'll bring that down. And then I'm going to bring out some studies. So we'll start with PA, okay? I'd like you guys to all start by doing 1. Once you finish 1, then we'll get a lateral. So these are all PAs. You know what, can we scoot that book? I just want a nice flat spot for these 2 guys. Great. So you guys can, there's just a bunch of PA studies right there. Start to pull from that. I'm going to bring ones around to each table. Each place. So again, we're all starting with PA. Go ahead and grab at least 1 from the stack.
There we go.
Yeah, you can go anywhere you want. Okay. Put that switch.
Sorry.
Alright, okay. And I'm coming around with the sticky notes.
Rest. So where's the sticky? Oh,
Here they are. I'll explain more in just a second.
He's okay.
What did you got here?
Okay. And then, yeah, you guys have already figured it out. Just grab a few of those. I'll bring these around. And hang on, and guys, I'm going to put on the board what anatomy I want you guys to label, okay? Cool. Just a sec. There will be more sticky notes up front here. If you run out, come grab more from up here.
What's wrong with it?
And then, yeah, you'll have to figure out which way to place the image, you know. Use the heart as your guide, or use the anatomic side marker as your guide.
These fall,
You just gotta stick them up in there harder. They'll stay. They're not perfect, but they'll stay. So we're gonna say apex.
And then do we just need like 1 apex, 1?
Yeah.
We don't, like all
You won't have to name. You won't have to label both sides. Yeah.
I like, these are gonna fall.
Okay, you got it?
So take a sticky note and put it at the top, and thicken it up at the top. Yeah, jam a couple of sticky notes at the top of it, like place them on there, and then shove it back up in there. Yeah, make it thicker. Yeah.
You caught it. Oh, she has a. You want you to do this? Look. Where's it? Where is it?
That one's looser because that's the one we always use, so it just gets used up.
So apex, clavicle, E11 is around here.
Angle. trachea.
That's just the top of the lung part, right?
Okay.
Oh, wait.
You got clavicle?
Arch, and we'll do.
Rounded upper area above the level of the clavicle.
Where's the clavicle? Where's the clavicle? Like the helium? The fuzzy part around here. A little higher? It's like the fuzzy stuff, right? So like a little bit higher. It's around the heart. The seventh right, come in. This is the right part.
Wait, isn't the,
Him,
Oh, that's the last one.
so, right?
Hemiadiaphragm.
Oh, yeah, that's right.
Or up.
Because it's
This thing.
yeah, I would.
You guys all look like you're up and running. Just when you get a moment, notice on the board I've given you anatomy to label for the PA, and then when we get to laterals, there's going to be anatomy to label for the lateral, some different anatomy. Okay. So start with your PAs or APs, and then we'll move on.
We did.
Keep these studies separate from the PAs.
yeah.
Guys, I'm going to bring around some lateral chest x-rays right now. Please keep them separate from the PAs so they don't
We
get
did apex,
in the wrong box when they go back.
helium, HILM.
I'm going to stick to your lateral right here with the smaller desk. And I'm going to stick some lateral studies right here.
And then right hemodiaphragm.
Perfect.
Hem, HEMI.
We don't want it off. Move it over. We'll just put it over
That.
So we're looking from the bottom. So this one, here's one. It's right here. So 1, 2, 3, 4, 5, 6,
The air
7,
filtration is right here.
9. That's at least 9. So again, it could be 10, but I just can't really tell. I'm pretty sure this one's here. To be all the way up there, so I'm pretty sure it's 10. Put it again.
Okay. Does everyone have enough room to work?
Yeah.
Yeah. There's space over here if anyone needs room.
I think we're doing pretty good.
The aortic arch. Anybody see arch? Yes. So that's
Right hand
left.
diaphragm, left prostotic angle. Bet you that's the
Seventh
right
rib.
in there. You got the hilum right. Left heart, as long as we're making sure that there's that big thing there, that's our heart.
So it's this one?
So the apices good, air filtration, same line structure.
On the left side.
So heart.
Same thing, cause they're,
Post 7th.
nice
They're-
and
oh,
short,
that's
so
this
7 on
one.
this side, match up with
That's this.
Oh.
So it's like right here. I mean,
Where?
Okay, that one goes up there.
like right here, no? Yeah, they are arch.
Point to it again, cause I think I lost it.
It's up.
Here?
More, you guys move right here to the right.
Okay. Got everything pre-labeled like that, and it's just put them on there.
The little arch.
The ones in the back are.
Oh, like on the boat on here. Oh, I see, like a little arch.
Little tiny, like you
Little
can see
tiny
it
arch. Yeah, it's like right here, huh?
So that's a 7.
How are you guys hanging in there?
like up.
All right?
That, like,
Okay.
Right
We've
here?
got an airfield trach, we've got a clavicle, we've got an
It's
apex.
like you see on this one, it has more of a bump than like the.
That's not the 7th posterior. That's the arch.
Posterior ones.
So once you get one
Stand
done,
down, right?
grab another one. So guys, I would like you to each do at least 2 PAs before you move on to the lateral. Okay, look at least 2 different PA x-rays.
This fits better when we do it.
Also, once you label them, make sure your name is on one of those sticky notes, and then when you pull it down, leave the sticky notes, leave all the labeling on there, okay?
No, so your sticky, the one that you have in your hand is right, the airfield trachea is right there, but this was covering your arch.
Okay.
Your arch is right there.
Oh, that makes sense.
Huh?
I think we just turned.
Oh,
it
yeah,
on.
you push
We
it.
just.
Gotcha.
Yeah, so I'd love to come check them. If you're, I'm gonna sneak past you guys. If you're pretty confident you got everything labeled right, you can feel free to pull it down and start another one, but if you want me to check, I'm happy to. Osteophrenic heart, 7th posterior rib aortic arch behind that, clavicle tighten up there, airfield trachea in the middle, apex towards the top as long as that's when the control point is there. Right hemidiaphragm is that structure, and there's your guys' names. All those are good things. They stay up there well enough once you guys put the little sticky
Yeah.
Yeah.
Okay. Good.
Save it.
Yeah, so again, keep the sticky notes on there, names on there, and then set it down somewhere, and then move on to a new one.
And you want them separate, so I'm gonna put them right.
Yeah, just somewhere so it's not, you know.
Let me do one more.
He's fine. Right in the middle.
No, just do it, just do it. Bam. Yeah, just do it.
Keep in mind, these are specific to the lateral positions.
Yeah.
Okay.
Excuse me.
You like it?
Sorry.
Wait, did we get them all? We got them all.
Excuse me.
Yeah. We just have to do 2.
Excuse me.
Okay, which ones are you?
You're already doing that. I started doing this already.
If you're a group of 2 PAs is fine, but if you're a group of 3, you'll need 3. One for each person. Yeah.
Oh, so we'll need one more.
Yeah, I'm trying to get 1 for each person at least before we move on. Yeah, good questions.
So we just need one more.
Yeah, where are we at on
I'm at right hemidiaphragm. I'll do airfield trachea if you do left
I
angles.
want you guys to get used to looking at an X-ray going, that's that, that's that, that's it, you get here.
Oh wait, I already did that one.
You already did left?
No, I haven't. I did the airfield trachea.
Helium.
Yeah, that's fine. That's a little heavy.
We have to count these.
Right. We can't see the. Oh no, it's him.
Oh, I'm in the way.
Sorry.
Right.
Yeah,
In the diaphragm. In the diaphragm.
aortic arch is
Left.
You already got your field?
Angle.
Airfield.
Oh yeah, I got airfield.
Okay.
What do you have?
That's a.
Here, let me write some, that way you can
Oh, I
go
have
do
that
it
one.
too.
I just need heart.
Okay.
I'm done.
This is so fun.
Javier's the dude. Well,
Hopefully you guys are getting used to like noticing anatomy now as you're doing this more. So again, as you're doing this, and as 2's a minimum, so there's no limit how many you can do. Start to look at these and evaluate them for positioning, start to evaluate them for exposure. Most of the studies we have here are repeat studies, meaning there was a reason, there's something wrong with them, most of them, okay? For example, that one in the back with you guys, that one shows rotation. Notice the ribs in the back don't line up, right? Good reason for repeat. Try to find the reasons why they were redone.
This one too?
That one? I don't necessarily see anything too wrong with that one off the bat, but if you look back at Yahira and Sarah's table, look at their view box, the one they have up right now, that one back there with them, Yahira and Sarah. Notice how bright that is?
Yeah, it's super bright.
KV was too low, it's underpenetrated. Can you guys see the spine through the heart back there?
No.
Faintly at all? No?
No.
Yeah, so underpenetrated, right? That's part of your quick evaluation that you'll do.
Oh.
You guys on this lateral find the aorta?
Then we just need one more.
Oh, you already got it.
Where's the aorta?
We're doing the laterals now.
No, we have to do one more because we're at 3.
Oh, fine.
Okay.
And these are laterals, right?
How many more, which ones do we need?
Remember the aorta is a big blood vessel, right?
I stopped on the left,
The aorta comes up
so
and goes behind the heart, like that. This big thing here,
So that
this structure here, that's the front of the aorta, that's the back of the aorta,
Yeah.
okay? And it's sitting up against the spine from one side or the other.
Okay, do it all over again.
Superimpose the spine, you just faintly see the
We're
outline.
3 people, so
That's all right.
Isn't that a-
I didn't have to worry about that.
Yeah.
Another important structure.
Because we're doing just the one more. I'll start the bottom.
What did you stop at?
Oh, okay. Wow.
So you gotta write the left contraflexion.
That's weird.
Okay, so this is the heart, right?
Yeah.
Yeah. Check it.
Not
Good, so we see clavicle, air-filled trachea, apex, good.
I was doing fine.
Trachea, there's our seventh rib. Show me how you counted to the seventh rib. I bet you're right, but show me how you found that.
So on the right side, on the left side.
So just put it on the shoulder.
A little easier. So what did you guys?
Oh, that's
count to the
rib.
left and then count to the right?
Yeah,
Seven
you
is
got
left.
on the right, but then we got the seventh right here. I thought the
So, show me where you think the first rib is on either side.
You kind of cut it off.
Yeah.
Here's the flag.
I was thinking.
Yep.
Okay.
Yep. That's the first rib.
That's been in 1, then 2,
Yep.
3, 4, 5.
Did you get the, aortic arch?
We nailed it. We got that on the right side.
You want to do
Good. Be real careful.
we're
I asked you guys to show me the posterior seventh rib on the left. And remember, their left is on your right. And we should have an anatomic side marker to help us with that too. So it seems like a goofy mistake, right? But it's such an easy mistake. We always make goofy mistakes. It's left and rights confuse people all the time. So really, really try to focus on that.
It's kind of hard to see. Huh? Yeah.
Right and the left. So you already have air-filled second?
Yes.
Air-filled trachea?
Yeah, we've
Okay, then we're
met in the
done.
middle.
Does it look good? It's really bad. But we have to be able to like, as an X-ray tech, like say like. So there's a number of things that I see on here, right? You guys see?
I can write them if you wanna leave, oh, you're.
They're not loose, if you look, they're, everything's pretty clear, right? Okay, so the arms in the way, right? Where's your, or, above, right, raised, and that one's not.
I'm like, oh, it's full. Yes, that's just
Never seen that before. But the arms in the way, right, superimposed over the apices. They're really, really rotated.
We have to do one more.
There's 3.
Right. Yeah, no, that's exactly what it is. They stuck their arm off you, so.
Okay, all right, good job.
Notice the
We did it.
posterior
So
rib.
let's do the,
Lateral. Where's the pile glass one?
That right there.
Oh, okay.
We'll switch.
You should still be able to find most of the structure there.
Here, let's switch colors.
Oh, cool, yeah. I'll trade you. Amazing.
If you hadn't noticed. I believe in color.
I like colors.
Oh, I see. Left, lateral.
Yeah, right there.
Clavicle on the other side.
There's a shooting in the Tacoma, Wells Fargo.